بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we are continuing the thoracic imaging lectures, and today we are going to discuss the issue of interventional radiology. Actually, this lecture is designed to give you, as a radiologist and also as a clinician, the most common available interventional diagnostic techniques for different thoracic diseases, so that you can select one of these interventional techniques whenever it is relevant to your battery of evaluation. And the lecture will not help you to perform these techniques actually, and anyone who wants to perform these interventional techniques should have a practical training, and this is available everywhere in the world, but this is, as I have said, is to give you the overview about the available techniques you can order or you recommend in your report for the physician to go with these procedures to reach the final diagnosis. The interventional techniques we usually perform in the chest include the most common procedure, which is the transthoracic percutaneous needle biopsies of pulmonary parenchymal lesions, also the biopsy of mediastinal masses, and percutaneous management of pleural collections, as well as management of intrapulmonary air and fluid collections. And finally, the pulmonary interventional angiographic techniques, including the bronchial and pulmonary embolic therapy. Then the first technique which is very common and is performed every now and this technique is the percutaneous CT or imaging guided needle biopsy. Actually, I will handle here the issue of CT guided biopsy because this is the way I perform in the interventional techniques myself, and I don't have enough experience in the ultrasound, and actually the MRI guided needle biopsies is not yet available in my country. Then the indications for needle guided biopsy include evaluation of pulmonary nodules or masses, confirming the diagnosis of metastatic lung disease, staging of lung cancer, sampling of suspected inflammatory lesions in the lung, and in some cases of diffuse lung disease, we may go to core biopsy in order to reach a final diagnosis, especially in some cases of interstitial pulmonary parenchymal lesions. Also, diagnosis of mediastinal masses, and in cases of focal or diffuse pleural thickening, we may also be able to have biopsies to confirm or to exclude the diagnosis of mesothelioma, for example. Then, as you can see here, this is one of the ways of biopsying a posteriorly located pulmonary nodule, which is suggested from the imaging criteria to be a bronchogenic carcinoma. As I have said, that you know, if you are sure about the diagnosis of bronchogenic carcinoma from the imaging and the clinical picture, and you should have a needle-guided biopsy to confirm the diagnosis and then to know the cell type, as I have mentioned in the lecture of diagnosis and the staging of lung cancer. And sometimes you may need to have biopsy such a lesion, which is a patch in the lung showing air bronchogram, may represent the pneumonic patch, but whenever the patient is subjected for the possible treatment for pneumonia and the lesion that did not resolve or even is fulminating or progressing, then you should know the exact underlying pathology, and you may need sometimes to biopsy such a lesion. Then this is a lesion which is approached from the back. I will mention in details the technique. And in such a lesion where a cavity is present or bronchiectasis are seen inside the lesion, you should try to avoid the areas of cavitation or breakdown, and you want to hit the wall of the cavity, because here you can have a sample of viable cells and you can reach the pathologic diagnosis. Then before you are going to biopsy a lesion in the chest, you should have first the adequate clinical data, and you should know the most likely radiological diagnosis from the films. You should inspect the films to design the approach for your needle, whether it is an anterior approach or posterior approach or lateral approach according to the accessibility of the lesion. Then if the patient is on anticoagulant therapy for any reason, he should discontinue this treatment for 5 days before the procedure. In many institutions, the consent signed by the patient or his relative should be available before the exam. Then you should have a look on the coagulation profile of the patient, especially the prothrombin time and concentration, as well as the INR. The previous CT scan or the previous imaging techniques should be available for planning a safe approach for your needle. Then if you look here, and this is an example of an anteriorly located lesion, and is intimately related to the chest wall. There is no lung tissue across the needle track, and this is a good approach rather than the posterior one or the lateral one, where you should pass through the pulmonary parenchyma to reach the needle, to reach the lesion. Then lesions abutting the major vascular structures, like in this case you are here in the region of the brachiocephalic trunk and the brachiocephalic artery as well. Then in order not to puncture one of the important vessels, whenever the lesion is adjacent to an area of major vessels, you should inject the contrast material to identify clearly the lesion separable from these vessels. Also, whenever you are suspecting that the lesion you are going to biopsy is a vascular malformation, then you should inject the contrast media and perform a dynamic study to be sure that this lesion is not a vascular malformation. Also, suspected hypervascular lesions like the deposits or some malignancies, you may need to inject contrast media sometimes, but this is not the usual case. Then the coagulation profile is very important, and the INR should be less than 1.3, and the prothrombin concentration should be above 70% in order to be more or less safe whenever you are biopsying the lesion. But if the INR is more than 1.3 and the prothrombin concentration is less than 70%, then you have a great incidence to develop post-procedure bleeding or bleeding during the procedure itself. Also, if you have an emphysematous bulla or severe lung emphysema in the needle pathway, you should be very cautious about puncturing these emphysematous bullae or puncturing a vascular structure in the needle pathway. This will result in the first case of emphysema of the pneumothorax, and in the second case it will result in bleeding. Then if the patient is unable to cooperate, then we may have to give him general anesthesia for the duration of the procedure, which is about 15 to 20 minutes. Then this will help you to reach the lesion if the patient is inoperable. Then there are a lot of ways to guide your needle for to biopsy the lesion, like the fluoroscopy, the ultrasound, and the CT scan. Actually, the fluoroscopic guided biopsy is now contraindicated because under fluoroscopy you are not sure about the nature of the lesion. It may be an aneurysm, it may be an arteriovenous malformation, and you will do a catastrophe to the patient. Then the most reliable techniques include the ultrasound and CT, and maybe recently MRI. And as I have said, I don't have enough experience with ultrasound, then I perform all the techniques using the CT guidance. And this is one of the most reliable biopsy needle, core biopsy needles available in the market, which here you can see different lengths of the needle, and you see the graded scale on the needle itself to know the distance where you are putting the needle inside the human body. And also you got different calibers of the needle, starting from the common gauges available, the 18, 16, and 14 gauge needle biopsies. Of course, whenever you go to the 14 gauge needle biopsy, you got a very big core, as you can see, and with the 16 gauge needle biopsy, you got a smaller core, which is also enough for histopathologic evaluation. Then this is the way in, to have the biopsy needle, and you have the biopsy needle with two needles inside each other. Then you puncture the skin and introduce the needle, both needles within each other, until you reach the edge of the lesion. Then you push the inner needle to be inside the lesion. Then you fire the needle in order to cut a part of the lesion and go inside the outside needle. Then you draw both needles outside. And here this is the technique. You review the previous imaging studies, then you put the patient in the position which is accessible for biopsy. And we have emphasized the importance of the accessibility of the lesion, or the intimate relation of the lesion to the chest wall, and also the absence of any emphysematous bully or major vascular structures in the needle tract. And also you should emphasize that there is no bone or rib obstructing your pathway to the needle. Then you put the patient in the position which was selected according to the site of the needle, according to the site of the lesion. Then the patient may lie supine like this one, and this one is also supine, or prone, or sometimes you put the patient in the lateral decubitus position and the side of the lesion is above. Then ensure the shortest and the most vertical pathway, and provided the vertical approach is the most easy one. But whenever you are selecting an oblique approach like this, then the adjustment of the angle of the needle will be somewhat difficult. Then localization scan is obtained to identify the site of skin entry, and you mark the site of skin entry by a marker on the skin of the patient. Then you perform an adequate sterilization of the site of entry and give some local anesthesia. Then you measure the distance from the skin to the central part of the lesion, and you mark this distance on the needle, and you push your needle inside the lesion. Then you take a section, or if you have a fluoroscopy CT, you can see the introduction of the needle until it reaches the site of the lesion. Then you push the inner needle and you got your core and you go out. After that, then you have a post-biopsy scans to be sure that there are no complications. And this is the skin marker about the site of the entry, and you measure the site of the entry from the midline. You calculate this distance on the film. This is the midline, and this is the site of puncture of the needle, and you measure the distance here is about, say, 3 centimeter, and you measure 3 centimeter, and you do some local anesthesia like here, and then you push your needle to the direction of the lesion. Then this is one of the most important issues, and whenever you are biopsying a lesion which is intimately related to the aorta or to the pulmonary artery. If you put your needle in a vertical direction, then if you miscalculate the depth of the lesion, you may puncture the aorta itself. Then it's better to align the lesion so that if you introduce the needle more than enough, it will not hit one of the major vascular structures. And sometimes we go from the lateral approach like this one, avoiding the vessels in the axilla as well, because this lesion is relatively nearer to the chest wall from the anterior approach or the posterior approach. Then this is what we call the lateral decubitus position. Sometimes, especially the lesions which are hidden underneath the scapula, and in the posterior approach or the anterior approach, you will pass a long distance into the pulmonary parenchyma. Then you put the patient in the lateral decubitus and aiming to displace the scapula more anteriorly. Then you can access the lesion in the intercostal space, as you can see here, and the needle has no path through the lung tissue itself. Then this is a lesion which is posteriorly located in the lower lung lobe, and we put the patient in the prone position, and this is the needle passing a little bit through the lung parenchyma, hitting the lesion, and you can easily appreciate this opacity, which means some bleeding in the pulmonary parenchyma here. Then after removal of the needle, taking the biopsy, and you should have scans to ensure if there are any complications. And in this patient, you can see some pneumothorax has developed after removal of the needle. And you can, if you look to the opposite lung, and you can see these emphysematous changes, which are the major cause of pneumothorax in most of the cases. Then what are the causes of pneumothorax? Actually, the incidence of pneumothorax in CT-guided needle biopsies of pulmonary parenchymal lesions ranges from 0 to 6 to 1, with an average 30% in all cases. And of these 30% of cases, about 6 to 7% require insertion of an intercostal chest tube. These are the risk factors of developing pneumothorax. Number 1 is the old age. Number 2, the presence of chronic obstructive pulmonary airway disease, and of course emphysema, intractable cough, and the lesion is deeply seated. And you see here, this is an example. You see this lymph node or mass which is present in the subcarinal area, and you want to hit this mass, you will go a long distance through the lung. And this is the needle, and you can see that the needle hitting actually the lesion, but the patient developed a large amount of pneumothorax because you have a long pathway through the lung parenchyma until you reach the site of the lesion. Then if the lesion is small and you have done multiple trials to hit the lesion or to take an adequate biopsy, then the incidence of pneumothorax will increase. Also, if you select a needle of a large caliber, and it will increase the incidence of pneumothorax. And I usually recommend the 19 or maximum 18 gauge needle for doing lung biopsies, especially whenever you are traversing lung parenchyma while approaching the lesion itself. Also, if you are biopsying a cavitary lesion, you may have the chance to put your needle inside the cavity, and then you got some air leakage, and the incidence of pneumothorax in this case will be high. Then hemorrhage is the second most common complication of transthoracic needle biopsies, and the risk of hemorrhage increases with unsatisfactory lab results. The coagulation profile is not good. The biopsying of vascular lesions, biopsying small mediastinal masses which are intimately related to the major vessels, the use of large caliber needle, and of course the multiple trials. And this is an example. You have this patient had a mass which is posterior to the superior vena cava and anterior to the hemiazygous vein. Then you cannot hit the mass from anterior or from posterior because of these major vascular structures. Then the only way is to cross the whole lung in order to reach this lesion deeply seated in the mediastinum. And whenever you go a long distance into the lung, the incidence of pneumothorax increases, and also the incidence of pulmonary parenchymal hemorrhage increases. And these arrowheads point to an area of pulmonary parenchymal bleeding secondary to this needle. Then other complications are considered very rare or even extremely rare, like the malignant spread of malignant cells along the needle track, which is very rare, and the incidence of air embolism is also very rare. Then the mortality rate of as a complication of transthoracic needle guided biopsy is about 0.02%, and the causes of mortality are tension pneumothorax, major hemorrhage, cardiac tamponade, and air embolism. Of course, the biopsy of mediastinal lesions is a little bit more difficult because of the intimate relation of the lesions to the major vascular structures in the mediastinum. Then the same way as for needle-guided biopsy of pulmonary parenchymal lesions are followed, including the assessment of the clinical condition, evaluation of the site and the size of the lesion, and the essential need for injection of contrast medium in order to clarify the major vascular structures which are in the vicinity of the lesion itself. Then we have different approaches for biopsying mediastinal lesions, like the parasternal or the transsternal, the suprasternal, paravertebral, transpleural, and transpulmonary approaches. And this is an example of a parasternal approach, and you pass your needle in an oblique way so that if you go deep, you will not hit the arch of the aorta, for example. And this arrowhead point to the internal mammary artery, which should be avoided actually whenever you are introducing your needle to biopsy such lymph nodes in the perivascular area. Then this is the transsternal approach, and you insert first a coaxial needle of large caliber through the sternum after determining the route of your needle approach to the lesion. And this is the retrocaval lymph node, this is the arch of the aorta, and this is the superior vena cava. Then you put the coaxial needle, and through it you push your needle, your biopsy needle, to hit the lesion. Then the suprasternal approach, and here you have multiple lesions, and you have an artery, and you have a vein. Actually, the importance of injection of contrast media is very clear here, and you put your needle above the manubrium sterni. Then you, in an oblique way downward, you push your needle until you reach your target. Then the paravertebral approach, usually you insert your needle as much as you can very close to the spine in order not to pass through the pulmonary parenchyma itself. Then in many times you have the costovertebral junction, you have osteophytes protruding from the vertebral body, which may obstruct your needle pathway to the site of the lesion. And many of the interventional thoracic radiologists sometimes inject a little amount of saline into the pleural space to initiate a track for the needle to pass through in order to displace the lung away from the needle pathway. I actually myself I didn't perform this procedure, but in many cases I try to go very close to the spine in the paravertebral gutter. I know you are here in the pleural space and away from the lung, and this is a mass in the subcarinal area, and this is a very good approach actually, which is away from the lung, and the incidence of pneumothorax is nil in these conditions. And this, what I have said, you may have the costovertebral articulation as an obstacle to reach this mass in the retrocaval area, or sometimes in old age you got osteophytes which may obstruct the needle pathway to hit the lesion of interest. Then we came to the drainage of pleural collections, and actually we drain the encysted collections and the empyemas, but the free pleural collection is usually drained by the cardiothoracic surgeons through insertion of an intercostal tube. And sometimes we may ask it to drain some of pleural collection in a patient with a very bad general condition. He cannot tolerate the insertion of an intercostal tube. Then we put our needle and try to use some valves in order not to introduce air inside the pleural space, and we aspirate as much as we can from this pleural fluid in order to improve the patient shortness of breath, which is a temporary procedure, not aiming to drain the whole collection. But in cases of encysted collection, or in cases of empyema like this, where you can see enhancement of the pleural reflections and the presence of multiple air loculi inside the empyema itself, we may insert a big tail catheter percutaneously and leave it for 2 or 3 days in order to ensure adequate draining. This is what I mean by the big tail catheter, which is a catheter with big tail, as you can see, and inside you have 2 metallic needle cores. And whenever you push these needles, you got a straight catheter, and this catheter is inserted percutaneously into the collection. Then you remove the metallic cores, and you got the big tail once more inside the lesion. You connect it to the drainage bag and leave it until complete drainage. Then this is good for the recent pleural collections, which has not yet developed fibrosis or loculation or interseptations inside the collection itself. If so, and you are draining a collection which is relatively old, then you may have to inject some of the fibrinolytic materials like streptokinase or others in order to remove some of the fibrotic bands to ensure adequate drainage. Then you know that chronic lung cavities may develop inside the fungal bole, and the fungal bole, as you know, is known as mycetoma or aspergilloma, and this is a major cause of hemoptysis, and hemoptysis may be massive and may result in death of the patient. Then in order to prevent this complication, we want to kill this fungus inside the cavity. And one of these techniques to kill the fungus is to inject an antifungal drug inside the cavity too many times or on several settings in order to ensure adequate killing of the fungus itself. Then the drug is known as amphotericin B and is dissolved in saline and injected through a catheter, fine catheter introduced inside the cavity where the fungal ball is present. Then here you can see the cavity which is free of fungus after death of the fungus itself upon multiple injections of amphotericin B, and this drug may be labeled with gel or lipiodol in order to prolong its effect inside the cavity on the fungus itself. Then we came to the vascular interventions, and there are two main goals for the vascular intervention. Number one is the opening of an occluded vessel, which is a technique commonly used for embolectomy of the major pulmonary emboli in the major pulmonary vessels. And actually, I don't know exactly if this technique is performed in my country or not, but I am sure that it is not performed by the radiologist, maybe performed by the cardiothoracic surgeons, for example. Then this technique is commonly done, which entails occlusion of any of these structures, occlusion of arteriovenous malformation or aneurysm or bleeding vessels or vascular tumors before surgical resection. And in embolotherapy, we use this technique to occlude pulmonary arteriovenous malformation or pulmonary artery aneurysm, for example. And these are the causes like TB, lung abscess, sarcoid, aspergilloma, bronchogenic carcinoma, chronic infection, cystic fibrosis, pneumoconiosis, and in these conditions, if there is an incidence of bleeding for a reason or other, then we may introduce our catheters to occlude the bleeder. And this is an example of two arteriovenous malformations. One is large and a smaller one, and maybe a third one here. And you may use for the occlusion of these pulmonary vascular malformation steel coils, as you can see here. And also, you remember I have mentioned this example before, which is the pulmonary artery pseudoaneurysm secondary to bronchogenic carcinoma. This patient had a bronchogenic carcinoma in the right upper lobe that has eroded the pulmonary artery on the right side, with the resultant small pseudoaneurysm here, which is amenable for rupture anytime. Then the risk of major hemorrhage is great in such conditions, and we introduce a catheter to demarcate the site of the aneurysm, and then we put a lot of steel coils at the site of the aneurysm and the pulmonary artery to prevent the risk of bleeding. Pulmonary arteriovenous malformations, I have mentioned a lot of information about these lesions in the lung, and actually you remember that this was an old technique to diagnose the pulmonary vascular malformation, is to insertion of a catheter into the pulmonary artery, injection of contrast media so that you can see the feeding artery, the AVM, and the draining vein. But for the diagnosis now we use the multi-detector CT, and also we can use the MR angiogram to confirm the diagnosis of pulmonary arteriovenous malformation. Actually, there are a lot of complications for the pulmonary arteriovenous malformations, like the embolic strokes and transient ischemic attacks. Also, the development of brain abscesses secondary to passage of the pulmonary septic emboli through the artery direct into the vein, and so on. Then This is an example of brain abscess secondary to this small arteriovenous malformation, which has been occluded by steel coil, as you can see here. This is the pre-embolization angiogram. This is the feeding artery, and this is the AVM, and this is the vein. Then after occlusion, you can see no flow through the vascular malformation. Also here you can see a small arteriovenous malformation in this CT scan, and this is the angiogram showing the feeding artery, the AVM, and the draining vein, and this is the occlusion of the feeding artery by steel coils. Then you have two vascular malformations here. One is the small, which has been occluded by steel coil. One is large, which has been occluded by detachable balloon. And this is a patient with hereditary hemorrhagic telangiectasia with multiple pulmonary arteriovenous malformations, as you can see here. And this is the post-embolization angiogram showing occlusion of all vascular malformations using steel coils. Then what are the criteria of accurate treatment of arteriovenous malformation? Number one is absence of any flow across the lesion after 6 months from the embolization date. Then a stable arterial blood oxygen level for 1 year, and the X-ray and this multi-detector CT showed no lesion and no flow across the site of the lesion. Then here you can see this is a post-embolization X-ray, CT, and angiogram showing no flow in the region of the vascular malformation. والحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين.